Perfect. So Sarah, do you want to start us off with a brief introduction and some of the work that you've done around data and evaluation and monitoring with SSPs?
Sure. And so, Amanda, I have some slides, and we planned less than 10 minutes for this, right? I just want to make sure I'm not going too far with my intro here.
No, you can go ahead and talk. So we were originally going to have an additional panelist as well, but they weren't able to attend. So we do have some more time. So, feel free.
Okay, great. I'm going to share my screen then with you all. Can you see those slides? Great. Okay. So first of all, thank you, Amanda, and everyone else at NASTAD for inviting me to be on this panel today. I'm really excited about it. I work in Seattle, Washington I really wear two hats. I'm an epidemiologist in our local health department and work very closely with our Syringe services program on data monitoring and evaluation. And I also work on faculty at the University of Washington. I am not in or from the South, so I very much appreciate you all inviting me into the space to share our experiences with you. Most of my work right now is actually with the CDC, focusing on national SSP monitoring and evaluation efforts. And so I'm happy to talk about that in the Q&A if folks are interested. Today for this panel, I'm actually going to be talking mostly about my work with our local SSP and the data collection and evaluation that we do here in Seattle. So I'll give you a little bit of background about our program to give you some context. The Public Health Seattle-King County SSP is, we think, the second oldest sanctioned needle exchange program in the United States. It's a very high volume program. We exchange or distribute anywhere between 5 to 8 million syringes a year. And our program has services in 2 brick and mortar sites in central Seattle. And we also have mobile services in North Seattle and then throughout South King County. King County is a very huge county, and so they have a lot of ground to cover. Our program operated as a one-for-one exchange, and we had plans to shift to more of a needs-based model called negotiated exchange. When COVID-19 hit last March, we used this as an opportunity to make an immediate change to our model. And so we've been continuing to operate more as a needs-based program ever since. And so with that background, I wanted to share with you all the 3 types of data collection that our SSP does, and then include an example from each of these data collection methods for how we've used the data to either evaluate our services or inform our community about the needs of people who use drugs. So that's how I'll be structuring the rest of this presentation. So first, I'm going to talk about our encounter data collection system, which is very bare bones. Participants receive services at our program anonymously. They do not have a unique code or a card. Data collection is done entirely by paper and pencil. For each client encounter, you can see here, we track the number of syringes that we distribute, and we also ask clients the number of people that they're exchanging for in order to track secondary exchange. Everything is added up at the end of the day, and it's entered into an Excel spreadsheet, and that's it. The method of data collection that we use here really allows our staff to devote nearly all of their time to the interaction with the client, and it mitigates any risk with respect to confidentiality or trust regarding data. There are downsides to this. The biggest of which is that we don't know how many people we serve, and that data would be really helpful for us in understanding our reach. And so that's one gap in our knowledge. But we still collect, I think, really rich data, even with this limited data set. And I wanted to give you an example of an evaluation I'm working on right now to look at the impact of changing our syringe distribution model. So this graph shows you the average number of syringes that we distributed at each encounter. And these data on the green line are from 2019, so that's of course pre-COVID. And you can see that number hovered between 150 and 200. But then when we moved to more of a needs-based model, you can see we give out a lot more syringes per encounter. This isn't rocket science, but it really shows the impact of making that change and clearly how quickly that impact was in March. And so this is just one thing we can do with that really simple amount of data that we've collected during our encounters. The second type of data I wanted to briefly share is our Naloxone data collection system. This is mostly supported by other health department staff, not myself. So I've been less involved in this, but I'd still like to share a little bit with you. We have 2 data collection forms here. Again, this is all done with paper and pencil, later entered into a database. The form on top is about 1 page long, and it's used when people first acquire naloxone from our program. And the form on the bottom is about 2 pages long, and it's used when people request a refill. And we attempt to collect data on that form on how the naloxone was used. We do ask for name and birthday and phone number here, but participants are not required to use their own, and they just have to use the same thing from encounter to encounter. And of course, if they're not willing to share this information or it doesn't match up or for whatever reason, we still provide them with naloxone. We just try to get this data when we can. And so I wanted to share just one quick example of how we've used these data. This graph comes from our annual HIV epidemiology report. And even though naloxone and overdose aren't directly linked to HIV, naloxone and possession of naloxone is still one of our key HIV program indicators. And so we use this to monitor the distribution that's going out. And then through other means, we can also monitor the proportion of people who have naloxone. So again, pretty simple data collection system, but we're able to get some good data from it. And then finally, I wanted to just share our experience conducting what we call a point in time survey. So this is sort of a trade-off for us. Because we collect such sparse data at each encounter, we put a lot of effort into collecting a pretty substantial amount of data every 2 years. So we attempt to conduct a 10 to 15 minute survey with every client during a 2-week period in the summer. And I co-lead this with our SSP manager. So he and I work together to develop the survey along with some other collaborators of ours. And then our staff and volunteers actually conduct the survey with clients. They read the questions out loud, of course, as privately as possible. And then the data are entered directly into a red cap survey. We don't provide incentives for this survey other than candy. And although we invite everybody to participate, it's completely optional. And we always prioritize receiving services before conducting the survey. Over the 2-week period, we typically get between 400 and 500 surveys. I won't sugarcoat it, it's a lot of work. Our team puts in a lot of effort during these 2 weeks, but the data have really been invaluable to us. First, this is what we use to estimate the demographics of our participants. So things like age and race and gender and housing status. Second, it's how we can estimate the percent of our participants who either are in certain circumstances or report certain behaviors. So this is how we can estimate the proportion of our clients who are still sharing syringes with other people, or the percent who report injecting alone. Third, we ask about client needs and preferences. So this includes anything ranging from interest in PrEP to types of treatment for substance use disorder, if they're interested in that. And then finally, we've used this to monitor drug use trends over time. And I wanted to show you an example of that analysis. So this is the figure that we update every 2 years to show what drugs are being used in our community. And this is like, in our point in time survey, we have a grid where participants check which drugs they've used in the past 3 months. I'm sure like a lot of you all, we have a lot of polysubstance use here in Seattle. So you can see that these will definitely sum to more than 100%. The clear shift for us here in the Pacific Northwest has been this dramatic increase in methamphetamine, both by itself as well as in combination with heroin, which is known as a goofball. And we have really been able to learn a lot about these trends using these data, which come from our clients, in order to see the broader trends in the community. And so in summary, I just wanted to say that our system has worked for us, which is a combination of minimal encounter level data with a periodic comprehensive point in time survey. On the plus side, this minimizes our client and staff burden most of the time with just short bursts of data collection effort every 2 years. It's relatively low cost, and I hope I've illustrated that we really do try to use all of our data that we collect. We don't try to collect any data that we're not going to use for some purpose. The downsides are that there are still data we'd like to have, including the number of clients we serve, as well as a way to track our clients over time. It would be really nice to know, for example, who's been tested for HIV in the past year when they come in, so that we could potentially offer them that service, but we don't have a way of doing that with our current system. So thank you so much for your time. I'm really looking forward to hearing from the others on the panel and being part of the discussion. I just wanted to add that, if you have any questions for me or want to see any examples that I've shared, or even examples that I didn't share but you're interested in, I'm happy to do that as part of the group that I work on, that's supported by the CDC, to offer more technical assistance nationally to programs. So I'm happy to talk about that as well. But for now, I will pause and turn it back to you, Amanda.
Thank you, Sarah. I did have just like a quick clarifying question before we move on to our next panelist. Can you elaborate on not the data that you collect? You don't know the number of participants? You're only looking at number of like exchanges or syringes?
Yeah, we know the number of encounters, but not the number of unique individuals.
And your program, or the data collection, is anonymous, right?
It is, yes.
Okay. Is that one of the reasons, or you just didn't want to add like the extra burden of unique participants to data collection? Can you just kind of elaborate on that decision making, I guess?
Yeah, of course. So we're still using basically the same program that has been implemented for about 30 years, or the same system that's been in place for about 30 years, which is that we only track numbers of encounters in order to minimize any potential issues related to asking people to provide any sort of information to link them from visit to visit. And so those decisions were put in place long before me. It is something we talk about a lot, and we talk about the pros and cons of shifting to a different system where clients can be tracked from visit to visit. I know, and I'm guessing a lot of folks on this call probably have a system like that. And there are certainly pros and cons to that, but our program as of now has decided to stay with this in order to minimize any data burden on our clients.
Yeah, and I was wondering too, if you can, because I think the immediate, especially from like just having worked in state health departments or for other state agencies, where it's like it's always like, how much data can we get from all these different programs? So I think it would be their go-to to obviously know that information. So I was kind of wondering if you can elaborate on some of the cons of collecting that information from a program standpoint, or why an SSP might not want to collect that information on their participants in terms of like number of people served.
Yeah, I don't know if there would ever be a downside to knowing the number of people served. I think that probably all programs would like to have that information, but in order to do that, you have to implement some system in order to deduplicate people visiting multiple times, and so it's just always a balance, right, between trying to get the data that you really do need in order to inform decision making and policy change and advocacy for your clients, with the burden on them and on your staff. And I know some programs don't have a choice. They have to report certain data to either the state health department or funders or what have you. So in some instances, it's not a choice. In other instances, you do have a choice. And I think it's just a conversation you need to make. And so we, like I said in the presentation, we really focus on this point in time survey, and then basically extrapolate those findings and guess how many of our clients are women, or guess how many are under the age of 30, or guess how many are people of color, based on the data we get from that point in time survey. So we know that like 35% of our participants identify as women. And so we just extrapolate and guess that that's probably what we actually see on the whole annual basis.
Awesome. Thank you so much.
Yeah, thanks, Amanda.
So we'll move to, I believe Dana wanted to go next. I think her camera is off. Is she?
Actually, Allison and I were chatting. The flow of her presentation fits better following Sarah's. So if you don't care to let Allison go next.
Oh yeah, absolutely. Allison, do you have any slides to share or just speaking?
Just speaking, no slides. But that's kind of, I think, like kind of in where I'm going with this, like may make some sense. So to introduce y'all, my name's Allison Gay. I work for the Louisiana Department of Health, where I'm the statewide Syringe Service Program Coordinator. And so one of the things that I was thinking about from this perspective of data and how it can help SSPs or health departments was kind of my dual background, right? I used to work at the Syringe Access Program, coordinated day-to-day and data entry, data analysis, and now I work at the Department of Health, and I see kind of both sides. And so going through, especially from a Southern perspective, some of the challenges that we're seeing, and I'm gonna speak a little bit more toward the health department folks on here, you know, but definitely, I think most of y'all know, probably have a good amount of community perspective thrown in, right? But so we have this lack of data of SSPs and people who inject drugs, people who use drugs in the South, especially in states where SSP isn't authorized, isn't legal, or states that don't have determination of need, right? And part of that is because we don't have the kind of back and forth two-way relationship that states that do have legal SSP enjoy, right? Where you are funding and contracting with an SSP in, for lack of a better kind of way of explaining it, in return for data coming back to your health department, right? That's kind of the pragmatic way of looking at it. And then from the health department standpoint too, especially within public health and STD, HIV kind of Hep C programs, we have this heavy reliance on testing data, right? But we don't necessarily see this kind of corresponding prioritization of people who use drugs to be included in, you know, the testing outreach, testing rollouts, and also within the people who are doing the testing, the agencies, right? So if you have, you know, a state where you can't above ground operate an SSP, and you have a region where you've never had a syringe service program, and you're relying totally on HCV testing data to know what's going on with people who use drugs in that area, that is such an incomplete picture. And so this is like the most low-hanging fruit that health departments, I think, can step in and start building those relationships where we bring SSPs, harm reduction agencies, whether they're legal or not, into the testing fold, right? Where we can fund testing for those programs. You know, I'm not a legal scholar, leave that to folks on the earlier plenary, right? But we can still fund testing at an SSP, even without a determination of need, because we're not funding their SSP activities, right? They're just staff who are then providing HIV, HCV, syphilis rapid testing. And that allows them to kind of build a structure and a foundation, not only for their organization, but also for the community they're serving, to feel more engaged and to be seen more. You know, unfortunately, from our perspective at a health department or a public health, I hate that this is the truth, but if you're not counted, you don't count, right? And so we need to figure out ways to responsibly work toward that. And then on the flip side of that kind of testing data and who's doing the testing, right? If you think about how most testing encounters go, you know, who is actually the volunteer, the staff member? Is that a person that is representative of community? And how does even that kind of, in Louisiana, we call it a Part 1 form. I'm sure everybody else has a pretty standard testing form. But if you're asking a ton of sexual-based risk questions, that could be more or less invasive anyway. And then just at the end, like one question, oh yeah, by the way, do you also inject drugs and share syringes with people? How is that going to, A, make people feel comfortable to divulge, you know, very personal details of their life and activities, or, you know, just even to say that this is a priority. So, you know, how can we rely on that data to show us how many folks are using drugs in a certain region or in a certain state? What is the need for syringe access? You know, so increasing SSPs and harm reductionists in that that work will strengthen everything that we're doing, from the testing forms, because we're getting better feedback from communities and agencies that have built trust and rapport with communities, right? But also we're just seeing more folks. And this is, you know, it's also a no-brainer. Why don't we want to be testing more folks in more communities who are at risk, right? And so, you know, if we think about it from the lens of other marginalized communities, and I want to say that we still have a long way to go, right? But if you are a person of color or lesbian, gay, and bisexual, or even a trans person in the South, you do have a decent chance of finding a testing provider where they may be employing people who look like you or share experiences with you. But we don't see the same thing for people who use drugs, only if you have an overlap with those marginalized identities. And so how does that also play out, right? So we have this kind of dearth here that we're talking about. And then we do have great data on harm reduction, SSP efficacy, and how, you know, like I'm preaching to the choir here, but as my grandma said, who do you think converted them? So we have this like real or perceived lack of specific data on people who inject drugs in the South. And we have a hesitance to use non-Southern data, especially from the perspective of policymakers, but also some of our peers within health departments and public health, right? And there is definitely some reason, you know, South above all, but, you know, people who are accessing a syringe service program in Baltimore, that data can be applicable here, but nobody wants to hear that, right? Let alone if we're going to talk about like how Tyler was saying in the plenary, Portugal or Norway's data. You know, you try to go to Bunkie, Louisiana and say, well, this program in Portugal is just like coming on like gangbusters. They're going to go, what the hell are you talking about? How does that work here, right? But then we're also pinned in on that because there is a very real and I think logical hesitance to reinvent the wheel when we have research, right? Because in the South, it's not like we have the same kind of options of different program diversity in every state. So we have to be really considerate of what data we're looking for, how we're researching that, and how we're setting up those projects, right? Because we don't want to have a negative knock-on effect on the harm reduction community by setting up, let's say, for example, a community-based, all volunteer-run, street-based syringe service program to be looking at testing and linkage rates to secondary services, right? That program is probably not the best one to identify there. And on the flip side, we don't want to go to a fixed site, fully integrated FQHC and say, hey, can you really look at the demographics of people who are not being served by SSPs, but still using injection drugs and at a higher rate of overdose and these adverse outcomes? Because that's not in that agency's wheelhouse, right? And so those kind of studies that might be challenged from the start could really have this negative effect on others, right? And so that is a really, you know, when we see that Southern harm reduction and harm reduction in general is still, unfortunately, something that we have to convince people, we have to have our elevator pitches. You know, we don't want to have a study floating out there as we did a year or two ago that, you know, was like SSPs are bad actually, because I think we all know that that is in fact not the case, right? And so then when we're looking at that hesitance for non-Southern data, it's also a moving goalpost, right? Because it's not just Portugal, New York, Washington, or San Francisco we can't use data for. If I pull data from Indianapolis or Louisville, my Southern peers are still going to be like, what does that matter? Albuquerque, New Mexico, even though we may have a lot of overlap with that. So it's not just the like, we don't want to trust the coasts, right? it's like we don't want to trust anybody outside of here. And so what we need to do at not only the health department level, the community level, CBOs, FQHCs, is to contextualize that data, right? Find ways of showing how there is overlap, especially when we're talking about, like, and this is a conversation I've had a lot. Well, what does Miami have to do with Lafayette? Well, here's some demographics. Here's some reasons why. We're all Southerners. We all love boiled peanuts, right? We all have funny ways of pronouncing different towns around our areas. So here's some ways why that might be similar. Instead of saying, well, let's go to Lafayette and figure out if we could recreate that syringe litter study, right? And so the final thing that I want to discuss about this too is intention and forethought when we are seeking that data out, right? Because we have communities who are marginalized, we know that. And we also, these communities have very real research fatigue, right? How often do our community members and the people we're serving have to, go for 20, 30, 40 minutes of invasive questions so they get 10 or 15 bucks at Walgreens? It's like hard to even keep the balance on that card, right? So we need to be bringing in not only those SSPs, not only the harm reduction providers, but also the community to drive those questions and say, what do we want to see? And on the flip side of that, right, also sharing that data so that people are truly engaged and involved, so that we don't have this whole stockpile of cloud-based data on risk factors, HIV, HCV, and we're not sharing that with anybody except people who know exactly what to ask for, how to ask for it, who to ask for it from, and then also do all of that stuff in triplicate, submit it via our, proprietary software to request data, right? That's not actually working for these communities. So how do we do that, right? And again, like probably every panel that y'all have been on and that we will continue to be on, as long as we're talking about these topics, is community engagement, meaningful involvement of people who use drugs. And that's not only from a staffing perspective, right? But also from CAB perspective, bringing people in and really talking to them about what do you want to see? And then thinking about what our considerations are for data collection, right? Both at the SSP level and health department level, I feel very strongly that we should never be asking for data that we don't have an explicit plan to use to support our communities, right? We know in research that we shouldn't be just asking questions for curiosity's sake, but that can be somewhat more nuanced when we're talking about drug use in our communities, right? One thing that I've been kicking around a lot, and maybe some other people may have this experience, and Sarah, I think, really showed a wonderful graph on that. But from a health department's perspective, why do we need to know drug of choice of SSP participants? Do we have a plan for how we're going to tailor services funding to specific regions depending on what the drug of choice and the demographics are? Or are we asking that more aspirationally? Right? We hope that someday we will get to a point where that will be helpful, and then we'll be able to help people. Whether that's 5, 10, 15 years, who knows, right? But that's going to be damaging. It's not only going to be somewhat invasive depending on where we ask it, right? I don't want to be asked what drugs I use when I'm getting an HIV test, right? But also if you say, not to sound like, I don't know, whatever. There's some saying, right, that like, I'm from the government, I'm here to help. I'm from the government, I'd like to know what drugs you use is not something that's going to make people feel super comfortable to like answer any other questions. And, what is the risk of criminalization or stigma? I, as a health department employee, don't want a master Excel spreadsheet of all the different drugs and how often they're used in every city and township in Louisiana, in every parish, right? That's not actually helping our services. I'd love to get to the point, but I'm not going to ask those questions until I have that plan, right? That's kind of the last bit of it. I never really had that kind of wind down, but most of y'all know me that I kind of never wind down in that way. So, well, cede the floor to my colleague, Dana.
Allison, thank you so much. I have so many questions, but I'm going to, or just like things I would want to pick your brain about in terms of this as someone who used to work at the health department and then at the, our behavioral health, basically state agency, which involved a lot of SAMHSA data collection. That was like, it can be very, very burdensome and like an actual barrier to services. And I just appreciate so many of the things you said. Certainly, what data is meaningful for funding purposes is really a good, key aspect of that. Certainly, like if there's ways to partner with health departments so that they can get the data, like testing data and stuff that you had mentioned, so they can show like, actually, we do need an SSP here, which obviously we would be like, well, we need an SSP everywhere, even if there's one person who injects drugs in this area. Obviously, like syringes being decriminalized would be great. We don't need a whole program focused around one person, but like in this kind of climate, I don't think there's a place where we wouldn't actually need one, but like having that data to show your need is really important. I do have some questions I kind of wanted to pick your brain about, but I'm going to move to Dana and then kind of come back. But yes.
Amanda and Dana, if you don't mind, there was something that you just brought up that I'd love to touch on before moving, and I promise I'll be brief.
Yeah.
To our colleagues at Single State Agency and Office of Behavioral Health, and also to our health department colleagues, the way that those agencies seek data and contextualize that is largely through, right, a capital R recovery lens, which is just by definition, multiple more pages and very focused on this smaller community. But as harm reductionists, we're talking about a community that is much larger. So our kind of concept of scale in data for harm reduction is just so much different than the scale for, your behavioral health or single state agency. And so it's really difficult for us to rely on existing data like that because it's not actually representative of communities that we might be serving or that might historically be not served, right? In the past few years, we've seen that the sharpest increases of injection drug use or injection opiate use are among the Black community, but we're not seeing that play out in the testing numbers, the treatment numbers, right? And that's, the full knock-on effect of like looking at this through the capital R recovery lens, where we know that certain communities are somewhat more prioritized, either by design or by accident.
Yeah, and just to touch on that real quick, and then Dana, we will move to you. But since you mentioned it, I mean, and my thinking of in terms of like single state agencies for substance use, a lot of all of the state opioid response or SOAR funding that those behavioral health agencies get, which some of which, can go to harm reduction programs, they're required to use the GIPRA, which is a very, very burdensome data collection tool. And, it's used by treatment providers and stuff like that. But once you start trying to give money, this was just kind of the experience we had in Florida when I worked over there, is that I think it's happening now, but we were trying to give funding, SOAR funding to the, syringe service program in Miami, not for syringe exchange or syringe services, but for wraparound services. Essentially for this grant, it was for on-site buprenorphine treatment so that we could do, mobile bupe and like rapid access to buprenorphine treatment under like a medication first model. Under that type of model, you're basically supposed to be able to like immediately give people access to buprenorphine, even if they're not ready for like any other aspect of a traditional substance use treatment program. And one of the things with that as well is not having intake and like data collection and assessment be a barrier to first receiving that medication. But since with that funding, everyone has to fill out a GIPRA, which can be like 30 minutes, it's like, can we even do a medication first model if we have to use this tool? So it's very tricky. And I mean, I know that there's, certainly a lot of folks who've been advocating to, federal partners about, this really does become a barrier to services. And I don't think that's what any of us want. So how can we really like improve this tool or make exceptions for, situations where this doesn't need to be collected and it's more important to save give this person life-saving medication without, first sitting through a 30-minute form. So I just kind of wanted to mention that, but I will move to Dana, and I'll stop talking for a second.
That's okay, go ahead. Honestly, I'm glad I let Allison go ahead of me in our talk order, because I did learn something very important from her that I think is going to be quite helpful for our participants to hear the Kentucky methods of developing our syringe service programs. My name is Dana Quisenberry, and I am an assistant professor in health management and policy at the College of Public Health. I do sit at the Kentucky Injury Prevention and Research Center. I'm their core director, as well as the surveillance PI for our Kentucky Overdose Data to Action funding received from the CDC. Okay, now I got to figure out how to advance my slides. All right, this is the part that was eye-opening to me, that there are those of you out there operating in the South harm reduction units without any legal authority. First of all, you are so brave. Second of all, I think you suffer probably from the same issues that we've had in Kentucky around providing harm reduction services. Being in the South, below the Bible Belt, Kentucky kind of sits right at the belt buckle of the Bible Belt. There was a considerable amount of our state leadership who believed there would never be uptake of harm reduction programs of any kind, much less any type of syringe exchange or syringe service programs. Our Senate Bill 192 in our 2015 session of our General Assembly, though, was a compromise bill in many ways. The idea of even authorizing the development of syringe exchange programs was driven largely in part by two things. One was the CDC report about communities that are vulnerable to HIV outbreak. Kentucky has 120 counties, 54 of those identified counties in the CDC's work lie in Kentucky. So that was a real shock, I think, for our state leadership, and kind of drove some action or some interest in providing action. The other thing was the outbreak of HIV in Clark County, Indiana, which is just across the river from our Louisville area. And that came as quite a surprise, because that is a predominantly rural community, not unlike some of the rural communities that we have in Kentucky. And so it provided some stimulus to the concept, well, we look like that, and it could happen there, means it could really happen here. So the compromise bill allowed local health departments there's a typo on that slide, don't look at that, to provide exchange service programs only in the event that the local government in which it intended to operate approved it. Kentucky, like many other states in the South, are home rule states, so there's a certain amount of powers that still lie at the local level, local health departments being one of them. So in order to give permission for the health departments to create a syringe service program, if you located it in the city limits, you had to have both the city council's approval as well as the county government's approval in order to establish your syringe program. So the concept there is not necessarily, it's onerous, don't get me wrong, it created additional burdens, but it also addressed one of those issues that Allison brought up of you have to have community involvement. So if it clears both your city and county governments, then you're going to have at least some buy-in from your community to support the implementation of the syringe program. Our state health department's role is, like it is in most local health department activities, is more of an advisory role. There are certain things, because of funding pass-throughs, that they exercise a lot more control over. But they did perform some work around providing guidance on how to implement syringe exchanges. And I gave you the link to the short document. There's also a long document. But there's some key points, I think, in that short document that's even helpful. The state also helps provide the centralization that's needed for the data that's coming from operating programs. And they collect a lot of the data similar to what Sarah mentioned. However, there's much more that's being collected. And so, the question that Allison raised, are we collecting data that then drives people out of the program, is an interesting question for us to ask. But all we see in the trajectory of operating of programs, both the development of new programs as well as the participation in existing programs, we continue just to increase both our capacity and our participation levels. The state also the State Health Department also works very much with this data and with the individual programs to evaluate effectiveness of the exchanges. One of the other things that they do that I did not put on this slide and will be the next harm reduction summit that is hosted by our State Health Department is going to be in July. And if you would like, Amanda, I will, when that opens up for registration, I'll be happy to share that, because we invite people from all over, and I think it's going to be fully virtual this year as well as it was the last year. So it expands the opportunity for others to participate, but I will gladly share that with you so that people can come hear more about what we're doing in Kentucky. But to speak more specifically about why I came here, this is the map that the green counties are those identified vulnerable counties in Kentucky. And when we first started with our syringe exchange, the only operating syringe exchange we had was in Louisville, which is, don't ask me to identify it on this map for you, you'll have to look at it. But it's more in the central part. But look what has happened over basically 5 years. Our syringe exchange, we have, I think, the most syringe exchanges in the state, but when we look at state involvement across all states. Really, the uptake that we had thought would be problematic because people would have moral objections or didn't saw it as enabling, whatever their excuses were going to be that had been floated at the legislative level. We haven't seen. And I'm going to highlight a couple of counties for you. When we get down here, if you can see my cursor, McCreary and Whitley County, in our southeastern county, this has been our staunchest area of usually religious objection to anything that is socially forward. It's also the area in which was the epicenter of the prescription opioid epidemic, and we had legislators stand on the floor debating Senate Bill 192 and said it will never be taken up in southeastern Kentucky counties. And look at it. It's just amazing to me the level of uptake that we have had when they gave the power to the local communities to make that decision. So what was intended to be a barrier of getting programs implemented has in fact failed, and actually may have benefited local communities in being able to establish syringe exchanges. Now, to me, this is all part of data. These are part of the things that we need to be able to talk about and have data around when it comes to making decisions about authorizing harm reduction programs. They can and do work. In areas where people think there's going to be objection, they still get implemented. And it's just fascinating to me that there are still legislators in Kentucky who want to roll back our syringe service program opportunities. We still have almost every legislative session a 1-to-1 bill proposed. So far, the last 2 sessions, it hasn't even made it out of committee. So we're really excited about that. So first of all, let me tell you a little bit about KIPRC and how we sit between the University of Kentucky College of Public Health and the Kentucky Department for Public Health. KIPRC was started about not quite 30 years ago now. And we are a state agency in that we are the bona fide agent for the State Department for Public Health around injury. So even though we are a research center at an academic university, we definitely play in a lot of times a very public health practitioner role when it comes to injury prevention. So that gives us a little bit different approach to the work than a true academic approach would be. So we started off with trying to come up with a way to support the local communities that were looking to implement syringe exchange. And I just pulled Jefferson County's county profile up. And as the county profile was initially being developed, the goal was to allow local communities to have data around what was causing non-fatal overdoses in their community. So it started as simply as what you see here. What's, when somebody goes to the ED for an overdose, what's the drugs involved? I'm not going to get into the data because that's not what we're talking about. But we quickly learned that there was a demand for more information. So even though we're an injury center, we started dabbling in looking at infectious disease through the lens initially of comorbid use with comorbid to drug use. And that then launched into, well, how can people measure when infectious disease may be attributable to drugs or may just be endemic in the community? And the thought process was to support syringe programs, we really don't care whether it was endemic in the community or it was driven by drug use. It became a chicken or an egg argument. It doesn't really matter which came first. Both are present and both need harm reduction services. So we expanded the county profile to include counts of infectious diseases, and that has even grown over time. We started initially with Hep C and HIV. We now do Hep A, endocarditis. We also look for encounters at the ED in which people were treated for something else but diagnosed as having a Hep A or Hep C, just to be able to start getting some prevalence numbers that were outside of the health department. This is utilization in a community, and people can get their head wrapped around that in a way that doesn't necessarily stigmatize, or at least we hope it doesn't stigmatize. And what we found, we started doing these in 2015. When the law passed, we added this additional amount of information. What we found is that our local health departments were able to win both the approval of their city and county governments with this data, because it showed it's not just people who use substances that create an infectious disease burden in our community. And that when you start getting people to be considerate of what's going on with the infectious disease burden, you end up being able to help both those, the screening for infectious disease, as well as providing other harm reduction services to people who use drugs. And that's when we started seeing the explosion of syringe programs, because they had data that was persuasive to the local communities. So this is some other standard data that you're going to see around overdose. We give them what the overdose counts look like by month. We give them the trend lines for them to be able to look. Once again, the data is less important than the products that we provide to them. We also started giving them more information about non-fatal drug overdoses. And hold on, I can't see it for the thing. Okay, this previous one is syndromic surveillance data. So it's the most timely data source that we have, although it has data quality problems. But this just lets us be able to depict for them what's going on overdose, because that is the pinnacle health outcome for people who use drugs, is either non-fatal or fatal overdose. So for syringe programs to have an idea what's going on in that space lets them know that maybe they need to speak about the risks being different when people come into the syringe programs. So, we're really excited that they have taken this, the language about the pandemic really having an impact. We see that in overdose, and we were able to get this data back out to syringe programs, and they were able to immediately start tailoring a different message about, injecting at different times than the people you typically inject with, so that you're not injecting all at the same time, that there's potential changes in the drug supply. I mean, there was a number of public health messages that changed during the pandemic so that we could take this big peak we saw of overdoses in May and June and start to bring it back down again. And honestly, pushing those messages out through our syringe program, which immediately got us the audience that was at most risk, was fantastic. The other thing that they were able to do is that feedback loop of data coming back to us. They were able to tell us that people were telling them when they came to the program that something was different about their drugs, that they were then injecting sometimes twice as often throughout the day, which increases their risk for overdose dramatically. So by providing this information out, we were then be able to get anecdotal information that supports the data that we saw, and are able to take that then to leadership and say, okay, we need to be doing something different. So it created a nice, instead of just us pushing data out, being able to get more data back in. So that was a quick rundown. I know that there may be lots of questions. I gave you on here the link of our county profiles, so if you want to see how they're structured and study them more in depth. And of course, if you have any questions, you can have my email address. Sorry, this house is an absolute zoo. I'm at my son's house. He's a firefighter, and everything around here is buzzing and
Thank you. I was going to ask. I wasn't sure if it was you or if I was about to make a comment to everyone to please mute themselves except for presenters.
Oh no, it was so me. It was so me. And here comes the toddler king right now. And he was actually good through the whole presentation. So thumbs up.
I'm glad he made an appearance. Yeah, Tina, thank you so much. So for folks, I have some questions I'm going to pose to our panelists, but for participants attending this session, if there's any questions or comments you have, please write them into the chat box and we will address those. Dana, thank you for going through all the different data that you guys collect. I do have, so I jotted down a few things when Allison was talking. And I mean, some of the things you mentioned were super valuable. I think one of them is meaningfully involving, I mean, we talk about meaningfully involving people who use drugs in like every aspect of program implementation. It's something that, you know, we certainly advocate for constantly. And when it comes to data collection, I know you had been talking about, you know, meaningfully including people who use drugs in even the types of questions that you ask, in, you know, that type of data collection, what they would want to know. Can you kind of talk about how that's been done in Louisiana? Like, were there processes that did involve folks who use drugs in types of data collection for syringe service programs? Were there focus groups done? Like, how was that input gathered?
Yeah, I mean, I can't speak to the past, right? And a lot of this is future focused. So there's a couple of things that we've done. One is, well, hiring people who have an overlap with like caring about SSP and like experience using drugs definitely really helps give you a perspective. And then another thing that we've been planning, because we're, and this might be actually more relatable to some of the other folks in the audience, right? We're just starting the process now of contracting our SSPs. So we were able to authorize syringe services in Louisiana. Unfortunately, we have a similar bill that other folks have talked about where you have to do local authorization. But we have 7 syringe service programs in Louisiana now. And so 5 of them we're in the contracting process with, which is really exciting. And so in our contracts, we've built in community advisory boards support within syringe service programs, and then have been discussing how we can integrate that into further planning. And we had a hepatitis C coalition in Louisiana that had kind of stopped meeting because we had gotten, done our modified subscription model. So everybody in Louisiana who's either incarcerated or eligible for Medicaid can now get treatment for Hep C. But so our Hep C coalition going forward is more focused on harm reduction and being inclusive of community members so that we can have a more equal split and not have power dynamics within those settings where you have a lot of well-meaning, wonderful white coat doctors and providers and case managers, and then like, you know, 2 or 3 people who use drugs, and one of them is the SSP coordinator, right? So we're trying to move away from that. And so that's really our structure, so that then we can consider what we're, you know, how we're planning, what we're asking. And we also have the privilege of being really intentional with how our forms look, because we already had syringe service programs doing amazing work in Louisiana before we started funding them. So we felt no reason to just say like, hey, here's our form, like, have fun with it. You know, it's more, how are we going to build this together? Bringing in our SSP coordinators, SSP staff, who are luckily, we're privileged to have them, that have a strong overlap with the communities they serve. So that way we can build it in at every level of the process, right? Community, SSP staff, health department staff, and then oversight.
Thank you. Yeah, and I was thinking too, it might be stuff that didn't happen before, but is going to be more intentional moving forward as more programs become operational. A question for everyone is really, what type of data, I mean, and this is currently going to be happening in Florida as well. I think our Department of Health here has rulemaking authority for data collection for SSPs, because for a long time, for the past couple of years, we only had one. And so they kind of were able to, you know, like there's certain data outlined in law that they have to collect, which is, you know, pretty basic in terms of like number of syringes collected and exchanged and stuff like that. Number of HIV and Hep C tests and things like that, that was, you know, written into law. But now that that's been expanded statewide for other counties, you know, there's, I think, most likely going to be rulemaking processes happening at the state health department level. And so there's certainly, you know, conversation with them and collaboration about making sure to collect data that is going to be used, that is useful, you know, that kind of stuff, and not collecting it for the sake of collecting it and then not really doing anything with it. So, I mean, I do kind of want to ask, like, from a state level, what has been your experience? But then I do have a question for everyone, and if others can chime in, feel free. But in trying to lessen the burden of data collection on SSPs, like, have there been examples that you were going to collect a certain data point and then, you know, kind of really thought about it or talked with folks and then we're like, oh, we actually don't need this? Or have there been ways that you guys have been able to, you know, make data and reporting pretty minimal for harm reduction programs?
That was for me or for Dana?
It's for anyone.
I can speak real quickly on that to something I mentioned earlier, which was about drug of choice. And that's actually something that I put a lot of thought into, because in the past, before I was with the health department, I was able to use that data that we collected on drug of choice to really expand programming, to move away from one-for-one exchanges, to really define like how many syringes people needed and set that as a baseline. So that's something that when I got to the state, I was thinking, oh, well, I wonder if we can do something similar. But then through conversations with my peers who are at the program level, some peers who are in our epi and data departments, you know, we've really put our heads together, and also, you know, speaking to like the community. Unfortunately, right now, because of COVID, I don't have as much of a direct line. And that has been challenging the last year. You know, how do we actually get meaningful involvement from our communities when we can't just jump on a Zoom, right? We can't, you know, I can barely get into GoToMeeting or Adobe Connect, let alone somebody who's using a library that may be closing because of COVID restrictions, right? So finding ways of really being intentional about that, and then scaling back, right? Like, you know, kind of the same thing, the same way you leave the house, consider data, right? Get dressed, look good, and then before you leave the house, take something off.
Well, and just to add to that just a little, I think that's an interesting analogy, Allison. Like I said, I'm so glad I've gotten to meet you virtually. I think one of the things that we have found doing that that truly public health surveillance of drug use is asking the question about drug of choice isn't really meaningful, because people's choice of drugs may not be what they get when they purchase. And yes, first of all, it's also not always a choice. You're right, that whoever put that in the chat, that's why I'm stumbling over that, because I have such uncomfortable feelings around saying drug of choice. Drug of preference may be a better way of putting it, but even that doesn't really tell us much from a public health lens, other than ways to messaging around safe injection methods or safe ingestion methods, because the drug supply has become so muddied, and people may prefer to use heroin, but what we've seen in Kentucky right now post the start of the pandemic is heroin is declining. It's not as available in the drug supply as it once was. So someone whose preference was heroin would go purchase something, they most likely are not going to get heroin. But so that messaging even is important. So, I mean, maybe making the ask, but I'm not sure what, kind of going back to what Allison said earlier, what's the intervention, because that's your particular choice or preference. Thank you for making sure I'm conscious about it. Yeah. I think there is quite a bit of work that still needs to be done about that. And I'm just going to throw this out there, Amanda. I really think your all's organization needs to find a different name for your division.
Like Drug Health Division?
Yes. Be people-centric, please.
Yeah. Good point.
I just wanted to add a little bit to that. Thank you both, Allison and Dina. One way that we have used data on what drugs people are using has been to really try to communicate to healthcare providers just how pervasive methamphetamine use is in our community, especially as we've seen this massive push toward medications for opioid use disorder. A lot of people, I don't think, appreciated that a lot of folks who need those medications are also using stimulants. And so we also have data showing that people who are using both opioids and stimulants don't do as well on MOUD when they're also using stimulants. And so thinking about treatment for just one type of drug at a time has not necessarily been the right approach. So I think our data has been helpful for that specific question. And then I just going back to your original question, Amanda, our best practices locally, whenever we develop any sort of data collection tool, are that we actually create an Excel file where we have our potential questions, and we have a column of like, who wants this data? We have a column of what is this data going to be used for? And if we can't make a strong case in that third column, we don't ask it. Even if we're curious and we'd like to know, if we can't think of a very specific reason that we'll use those data in a timely fashion, right? So if we aren't going to use those data in 2 years, we don't ask about it. And so that's been one check on ourselves for making sure we're only asking about data that we actually will use.
That's an awesome tool. I love that. Because yeah, I mean, there's a lot of data where it's like, I mean, Allison had mentioned it, like it'd be nice to use this to structure funding, but if we have no ability to do that, then why are we going to be collecting it for the next, especially within state systems, changing a data system, or I mean, I've seen it happen so many times where it's like a 10-year process or like a 5-year process. So it's, you're not going to end up using a lot of that data. I think by the time you're able to maybe meaningfully, give funding to programs based on it. Sarah, I did want to give you, we have about 5 minutes left, and I did just want to, for a minute or two, if you want to just mention the technical assistance work that the University of Washington offers surrounding data through the CDC for folks that are on the call.
Yeah, sure. So we were fortunate to get some funding from CDC along with you all at NASTAD and our colleagues at National Harm Reduction Coalition to support monitoring and evaluation technical assistance. So for SSPs. So basically, if your program is either looking to change their data collection system, to expand it, to I guess decrease it, to do anything differently, or if you just have questions about what best practices are or need support for moving from point A to point B on some element related to data, you can reach out to my team at the University of Washington, and we are building up a center to provide you with that support. And that could be done from staff that work at the University of Washington with me, or through a growing network of mostly other SSPs who will be able to work with us to provide more peer-based support and technical assistance. We actually just had a call immediately before this meeting with them. So everybody is raring to go, and we're really excited to be able to do that. We will also be working with our partners at NACHO to put out a call for proposals to support programs, to give them money in order to do these things too, to beef up their data collection systems, to change them, to get new software or new hardware in order to do the things that they've wanted to do. And in parallel, we can provide technical assistance alongside with that. So that is forthcoming. I don't yet have a date. I would have loved to have a date for you all when that will be released, but I think it will be later this spring. And so we'll be sending that out through, probably largely through NASTAD's email list, since you all are already connected through that. So be on the lookout for that. So please reach out to me if you have any questions at all. A couple people already have through the chat. So I appreciate that and look forward to hearing from more of you.
Yeah, thank you. And Kelly also put in the chat the link to request TA from, I think, the CDC. So there's a couple different types of TA offered through the National Harm Reduction Coalition, NASTAD, which, you know, are a little bit more programmatic, but the University of Washington, where Sarah is a lot of TA around data and evaluation and monitoring. So if health department folks or other programs want to reach out about that to make sure that, you know, I think that tool that you mentioned is just like probably one tiny, you know, piece of really valuable information that, you know, making sure like using is not just having a conversation about like, well, are we going to use this? But like having it in a spreadsheet. And if you cannot make a very clear, you know, distinction or connection that this will be used in a very timely manner at this time, then we don't end up using it. So that's, I think, one example of something that is just very useful for folks that are gonna, you know, a lot of the times we have to collect the data that like we're, you know, tied to funding for. So that's why having these conversations with folks at the state and federal levels who might be determining what kind of data is collected is very important as well. So we have about 2 minutes left, and I wanted to, yeah, kick it over to you guys for any final thoughts and closing.
I actually have a bit of a challenge that, as someone who works with secondary data sources constantly or daily, one of our upcoming challenges is to start having reflection in data collection at the primary level of non-binary gender. And this is something that, once again, I'm now going to have to put it through that lens that Sarah has for us. What am I going to do with that information and in the next 2 years? But it poses a lot of challenge with basically every established infrastructure that we have in any of our social organizations and our governmental organizations. The binary gender data collection is problematic, particularly in helping to identify risks that are unique to different populations. And I do not know how to answer that, but I imagine that those of you who work in syringe service programs might have some ideas. So I would love to get some feedback about that.
Yeah, good point.
I'm always up for a conversation on that.
And
I'm
Alice,
sorry, I didn't hear you, Allison.
I am always up for a conversation on non-binary, gender non-binary data collection and whatnot.
It's a real problem because at this point, for us to understand the burden adequately, we don't have the information at hand to do that.
so we are at 3 o'clock. Allison and Sarah, did you guys have anything to close out with before we end?
I did. I just wanted to thank Dana and Sarah and you, Amanda, and everybody who attended this. I feel very privileged that Sarah was involved, authored a really wonderful paper this year on SSPs during COVID that if you haven't had a chance to see, you should definitely look out. And to Dana, every time I see that Kentucky map with all of those stars, it makes my heart like the Grinch, where I'm just like, the work that y'all have done to get so many SSPs in so many places that are necessary is something that we all can aspire to. So.
Thank you, Allison. Like I said, every now and then we do something good in Kentucky. This is one of the things I think we've done well. So I'm happy to share with our sister states in the South that it can be done when everybody else is saying it can't. So.
Thanks for those kind words, Allison. It was great to see you all on the panel, and yeah, just reach out and let me know if you have any questions or would like any assistance related to data collection. We're happy to help.
Yeah, thank you all so much for presenting. And we will, yeah, please reach out for technical assistance on this. I feel like I even have a lot to learn and have learned a lot throughout this session and just like brainstorming a lot about different data collection. But thank you so much to all three of you for attending. Just to